Okay, we'll move on with the programme, and I'd like to welcome Alison Ryan as she makes her way to the stage. Alison was Chief Executive of the Princess Royal Trust for Carers. She is Chief Executive of Wellmar Hospice Care Trust based in Dorset, but her hat she's wearing today is as a Non-Executive Director of the Strategic Health Authority, the South West Strategic Health Authority, and is going to reflect on the discussions and outcomes in which we've been involved in from a task and finish group. It's quite finished, but anyway, it's certainly a task group that's been looking at the relationships and engagement of social purpose sector with health, and I know from being involved in the meetings that Alison has chaired that she's absolutely determined that there are practical actions and recommendations that come out of that group. Thank you very much, Alison, for being here today, and indeed yesterday. Over to you.
Thank you very much, Steve. Good morning. As you'll see from the reader biographies, I've been around as a Chief Executive in the voluntary sector in health and social care for 25 years. I'm one of the founder members of Akivo. And I should say for most of those 25 years there have been projects going on looking at improving the relationship between the NHS and the voluntary sector with remarkably little effect. Under the previous government, the Department of Health decided they needed to have a go at this one, and they were going to put this through Akivo and through the strategic health authorities. A lot of eyes swiveled in my direction as I seemed to be occupying that position, and I instantly decided to go on a long holiday to the Arctic. And sadly came back, and that was before the white paper and the election. So if you really want poison chalice, this was it. So what did we do? We gathered together a working group of people who knew, and that came from a mixture of the NHS commissioners in particular, the voluntary and community sector, and that was a mixture, interesting mixture of infrastructure groups, both regional and local, and service deliverers such as myself and others, with a real range of functions and size, in particular size, and that was, we thought, very important. What you've got on that slide is the kind of traditional third sector roles where they impinge on health, and we agreed that those were the kinds of things that we all got up to, and we took a stock take. Between us, we awarded ourselves marks out of 10 for where we were in the relationship between the health service and the voluntary sector on all of those, and we kind of averaged between 5 and 6 out of 10. It was not particularly good, and we set ourselves the very limited ambition of moving that from 5 or 6 out of 10 to 7 or 8. So we're not looking to change the world, we're not looking to cope with everything, but we're looking to identify specific actions that might make a small difference to a lot of people. So we then did some more work trying to see where were the opportunities likely to be at that interface, and that's what is on those slides. Clearly commissioning terribly important, but also strategic planning and making sure that the users are in the focus of everything that happens and getting really good feedback. Issues about developing the capacity and leadership to deal through difficult times, and all the issues around innovation and those rather drastic changes that come under the heading of QUIP. And I shall be looking at those because we then focused those even more to get more of a focus on what would happen, and QUIP came first. The other thing was public engagement as being something we could really look at in right here and now. We needed to do something that wasn't particularly airy-fairy but would have some legacy in all this uncertainty within health planning that might let it last beyond whatever happens. And I'm not going to say what's going to happen because I haven't a clue, and neither has the Strategic Health Authority, and that's not Chatham House rules. No one's got a clue, including quite possibly Mr. Lancy. Because life is uncertain, you know? We're definitely not trying to save the world, and we're definitely not trying to save the NHS here, but we are trying to identify the things that will just make the hiatus come out better for patients in the long term. So we're going to take all those three in a bit more detail because that's where the action plan comes. The status of the action plan is that we finally agreed what we think is on it and the general wording yesterday morning, which is why it's not entirely clearly up here. and we'll move. Oh, don't do that. I hate it when it does this. Thank you.
Alison, would you just like to remind people quick what QUIP stands for?
I was just going to on this slide, which says QUIP. I remember Steve from our meetings. What is QUIP? QUIP stands for Quality, Innovation, Prevention and Productivity. It's the only game in town right at the moment. If you're a PCT, if you're in the NHS at all, your preoccupation is how are we going to maintain quality service within the amount of money we have at present and are likely to have in the future. And as you all know, the NHS has been safeguarded from cuts. We have fat cash. Unfortunately, the demands of demographics and the demands of advancements in medical technology mean that there is a very, very substantial gap appearing in 3 years. It's at least 20 million, probably 20 billion, what am I talking about? Probably 25 billion pounds. And some of us are planning for much, much bigger savings than that. The approach to it is to put quality first, and it is about eradicating the NHS's really, really bad habit of spending vast amounts of money doing the wrong thing. And in particular, the opportunities are in long-term conditions, mental health and end of life, where that is, as most of us who are working in those areas never have, know that the NHS approach has sometimes been very counterproductive and has wasted money. So it is about being imaginative and eradicating that waste while also improving the patient outcomes, carer outcomes. And clearly I think that instantly flags up to me that there are huge opportunities for the voluntary sector. The first of our recommendations is that the voluntary and community sector should be engaged by QUIP working parties, and these exist at PCT level everywhere. They're being monitored by the Strategic Health Authority. And in this area, that means they're being controlled very heavily by the Strategic Health Authority. We're pretty hands-on, which is why we're so good. The engagement of the sector in the early planning is really important. What we found is that there's a tendency of the NHS to do the planning, do the thinking, and then pass the bits off to the voluntary sector. We have so much to offer in terms of our expertise, our knowledge and our insights, especially from our exposure to patients and carers. So it is about that engagement. Now, what we did think is that that needs to be done in quite a careful and mature way, and there is a role for the infrastructure organisations to help that process along. There is a requirement, if you want to be part of that game when you're a voluntary sector organisation, to adopt some pretty mature behaviours around Chatham House rules, about not taking those little nuggets of fear and starting to use them for lobbying for your own individual purposes, but by being part of the bigger picture, being part of the health economy. But we were anxious that that involvement of the voluntary and community sector in QUIP planning should be early rather than late. One of the things that QUIP is trying to identify are the indicators for where commissioning done differently or of different things would produce success. What are those key performance indicators? And we will have some views from our work with patients and carers about what they would be, and we need to be sharing those with the National Health Service, but also the NHS needs to share with those of us who might be delivering some of that, what that currency is. So for instance, you need to know what evidence you can produce of those outcomes and improvements to your patients and carers in terms of the cost, productivity and prevention agenda of QUIP. And you need to know what that currency is, and it's not clear at all. It's partly not clear because some of this is really difficult stuff, and it's being invented by the NHS as it goes along. But it does need to be shared with us to give us a chance then to say, well, hey, if that's what you're trying to do, don't do it that way, do it this way. It happens not to be my organisation, it's my wife's organisation does that. That's mature behaviour. Or it is my organisation. That's doing what your job is. So we need to share intelligence and that, and some of us know it in the room. You know, we need not to be too precious about having our inside track, and if you've got an inside track, you need to be able to share that too. The third one on this slide is about maintaining the user focus. We are all, I think, very concerned that the knee-jerk reactions, the siege mentality means that actually the QUIP, the Q of the QUIP, gets lost in the P of the productivity. And we retrench into services that are manageable and doable and will just get by, but don't really do the different thing for users. There's obviously real role for the voluntary sector there. In all this, the engagement of the voluntary sector is hard for the NHS, as the voluntary sector is so diverse. And across the local infrastructure organisations are key who animated this, bringing it together in a way that the NHS can work with. Which again means that you have to be not too precious about your own organisation, but be prepared to spend and invest your time as VCS organisations in your local infrastructure organisation. And we are very well aware that those infrastructure organisations themselves are not all of the same quality. So some parts of this patch, they're pretty rubbish, to be perfectly honest, and some parts, they're wonderful. And we need, as a regional outfit, wake up, to do something about that. Staying on QUIP, because QUIP is the big one. It's a big opportunity. It's the biggest lever I think we've ever had, really, for getting in there and getting this sorted, is our need to be able to respond to the commissioning and tendering opportunities. Now, we don't know who's going to be doing commissioning quite, we don't know quite what the tenders are going to look like and what the contract relationship is going to be between the sector and the NHS in the future. But we shouldn't be unambitious about it, and I think what we've been tending to focus on is our role as providers of services. I think what we should be thinking about is that with all these people doing commissioning in the future, they need to know what good commissioning looks like. They need to know what it looks like from the patient's point of view, and they need to get that information, those insights from us. And I don't think we should be coy in seeing a role for ourselves in developing commissioning and super commissioning. And you might say, well, there's a conflict of interest. There is. I've run large organisations at the national. There is no conflict of interest if you're in a large national organisation sitting on the knee of the minister telling you how to do commissioning. That seemed to be your job. We shouldn't be coy about it locally either. And again, it's about maturity of relationships, not seeing the bigger picture because you're pursuing your own individual organisation's aims, but actually working on the development of commissioning as well as your response to tendering. But you must be aware that if you're a PCT and you're up against it and your management budget's just been slashed by 43%, which it has, so all these guys are extremely busy and leaving and not being replaced, then you have to make it easy for them to work with you. And that is about working in consortia. And again, it's about not being precious about your own individual aims, but keeping in your mind, who are we working for, what is this about, and how can I work better with other organisations to present a wider case to the NHS to get that money, because actually those patients, those users, those people in the community you support are the ones who will benefit. And sometimes that means moving across sectoral issues, and Marmot so clearly said to us, this is not just about health, this is about everything else as well, and maybe you should be looking at making those alliances into education, into housing, into road safety, whatever, if you can produce the evidence.